We're going to start. It's 8 o'clock here in Toronto. Good morning, good afternoon, good evening. My name is Gabriela Gizzi. I'm the secretary of ICCPR and your host today. So thank you so much for joining us. I know it's late for some of you at night, so we really appreciate, and we are very excited to be hosting our first ICCPR webinar around the world. The topic today is COVID-19 and cardiac rehabilitation. We have 9 amazing speakers that will be talking to us today. But before we start, I know lots of people were invited by our members and are not aware of what ICCPR is. So I want to just very quickly talk about our council. So ICCPR, it stands for International Council of Cardiovascular Prevention and Rehabilitation. It is a group of 38 associations around the world and some friends. The goal is to bring together national associations around the world to harmonize efforts in promoting cardiovascular prevention and rehabilitation. And really, our goal is to learn from each other so that we can give our patients the best possible care. And never has this been more important than during the COVID-19 pandemic. We have different strategies and different projects going on, and we are very excited to launch today with this webinar, the Global Survey of Cardiovascular Rehabilitation Programs related to the COVID-19 impact. So this will be a brief online survey that will access the program characteristics, CR services available to patients during COVID-19, barriers and needs regarding CR service during this pandemic, and the impact on staff. And we will use this information to identify major gaps in CR care and to consider the mitigation strategies to address these gaps. So stay tuned on your emails and complete the survey if you receive it, and share with your colleagues, please. Okay, so these are the goals for today's session. So by the end of the session, we want you to learn, and also we're going to be sharing some important information on how to adapt our practice and continue the care of our patients during COVID-19 pandemic. Specifically, our speakers will be identifying common challenges. You're going to be able to learn available resources that can help your program. And you're going to learn about virtual home-based strategies that can become a part of your patient's long-term care. So before we start, I'm just going to mention to you, you have a Q&A box on the bottom of your screen. If you have any questions during the presentation, please use that Q&A, type in your questions. At the end of the presentation, we will do our best to answer all questions. If you don't have your questions answered, during the presentation, don't worry, just go to our globalcardiacrehab.com website, and we're going to be posting later the answer to all questions. Now, we are going to, let me see if I can do that. No. We are going to be launching a poll just to know who are you. Let me see if I can do that. Sorry. Yes. Perfect. So here's the pool. We have 3 questions. Which region of the world are you from? If you can select one, which alternative better describes your role in cardiac rehabilitation, and if you have stopped delivering cardiac rehab programming. During the COVID-19 pandemic. If you can please answer those questions. I'm gonna be ending the pool soon. Thank you. So we have the majority from Asia. I don't know if, I can share the results with you. So we have the majority from Asian. We have people from Europe, from North America, South America, Australia. The majority are physiotherapists and exercise physiology and exercise leaders, but we do have representation from all different sections of cardiac rehab roles, and the majority had to stop delivering CR. Okay, so let me close this. So I'm gonna meet, so how we're gonna be doing, we have 9 speakers, as I mentioned to you. I'm gonna be presenting in blocks of 3, so you're gonna be hearing about, I'm going to be introducing 3 of them, and then they're going to be presenting, and then I'm back to do 3 more, and then the final 3, okay? So the first 3 are the ones that are showing in this PowerPoint. First one is Professor Robyn Gallagher. She is Professor of Nursing and Faculty of Medicine and Health at Sydney Nursing School in Australia. She's the past president of the Australian Cardiovascular Health and Rehab Association and past chair of the Cardiac Society of Australia and New Zealand Cardiovascular Nursing Council. The next presenter is Professor Gerson Cipriano Jr. from Brazil. He is associate professor at the physiotherapy department of University of Brasilia in Brazil, and also a research scholar at University of Miami. And the third presenter of this first block, it's Robert Bertelink. He is the clinical coordinator and cardiac rehab supervisor at UHN Toronto Rehab Cardiovascular Prevention and Rehabilitation Program in Toronto, Canada. So we are going to start the presentations. Professor Robyn, you're first.
Thank you very much. It's a wonderful opportunity for myself from Australia to be here in this wonderful group of people. And I do hope that what I can discuss today is helpful to you. I'm just going to check with Gabriella that my slide is being seen in its full extent. The first slide, is that?
I can see it, yes, yes, yes.
Thank you so much.
Thank you so much.
So just a little background on Australia. Australia is really quite a large country. At the moment, we have the benefits of being an island, which some people don't have. One of the key features of Australia, although it is about the same size as Canada, is we have a small population, and our population is greatly concentrated in big urban cities like Sydney and Melbourne. But the rest of Australia is extremely sparsely populated. So we have been using some telehealth methods for some time to address people's needs. We were asked to talk about our typical target population, and as you can see here in table 1, The age of our patients on average is 66. It's an older group. Most of our patients are male. We have a small Indigenous population who is at very high risk, but we are a very culturally and linguistically diverse country. Most of our patients are surgical and STEMI, non-STEMI patients. We have very few smokers, but very high rates of obesity, and surprisingly, we have some depression. Like most of you, I think that many of our eligible patients don't attend. We have fewer young, very old people come, women, carers, and long distance. So we already have some problems that we need to address. So briefly, the COVID-19 changes that Australia is experiencing is, of course, like everyone else, a requirements for physical distancing. This means that our non-essential outpatient-based services must be limited, and we must have no groups. So our cardiac rehabilitation is primarily delivered in outpatients of hospitals. So most of our group services have shut, and we have been required to deliver our services mostly remotely or indirect. The other situation we're facing is that staff are being deployed to acute patient care, such as COVID-19 patient care and screening. So it's one of the battles we will face. We are finding really strong indications that cardiac patients are avoiding coming to hospital for acute symptoms. We have had a massive decline in ED presentations for chest pain. Patients are also avoiding coming to clinics for follow-up and to their family doctor for testing and general health care. We think our cardiac rehab population is at increased risk of poor diet and negative coping strategies, such as more smoking and less exercise. Right now, exercise is being strongly encouraged through media, public health, every opportunity. We don't have outside restrictions apply, but we are only allowed to exercise with the members of our immediate family, and we have to exercise social distancing, such as we're not allowed to travel outside of our suburb, there's no gyms, swimming pools, and some beachside restrictions. So the responses, I think that in Australia, we're trying very much to think about the opportunities that our current circumstances provide. And our federal government has, for the very first time, funded telehealth-based appointments. This is a really landmark opportunity. And part of that is there's better electronic integration of tests, prescriptions, and pharmacy. We're being encouraged to use new methods of delivery, whereas in the past we weren't. Our Cardiac Society, of which I was part, has developed a position statement which, for the very first time, really clearly supports the importance of secondary prevention and cardiac rehab. So most of our services are being maintained. One of the other opportunities is we are empowering patients to home monitor. And so there's been some necessary and long overdue changes in delivery. Just talk briefly about some of the strategies, and I hope I address most of the strategies that my colleagues are implementing. Inpatient referral remains. So cardiac rehab is still doing inpatient referral. We're using online platforms, and like most of the world, we're using Zoom most frequently. But we also use Microsoft Teams and Skype. However, many of our local health districts are concerned about privacy, and so we're using a platform called Pixip. We have some commercial telehealth programs already called Coach and CardiHub as examples that have got proven evidence. But the problem is with costs and availability, they're really a little bit difficult to get set up in a short period of time. We are emailing patients and we're including links and resources. So we found that most of our patients are on email. Using landline calls, we're encouraging the use of mobile apps and trackers, which we can then get patients to send us screenshots of so that we can discuss them. Recently, the Heart Foundation of Australia has provided, well, it's always provided resources, but right now it's providing a free text messaging and telephone service for heart attack survivors. And so all of our cardiac rehab services are encouraging patients to register for that. We also have been using the British Heart Foundation, thank you, exercise resources, and Cardiac College from Canada, thank you, workbook resources. We're finding that case management's a good idea, where one provider helps build rapport and continuity with the patient. We're also finding that multitasking is necessary and removing some of the discipline boundaries between exercise and nursing and medicine, for instance, and we're continuing to measure outcomes. The challenges we're facing are, I think, common. All of our staff are requiring to upskill to learn about online, email, phone, and video strategies. And video strategies are not easy, particularly if you're thinking about delivering to a group, how you can manage your visual at the same time as watching individuals. And one of the things we've learned very clearly is you have to have an assistant who can be looking at the videos of people. And you have to help patients and participants work out those videos. We're finding change management in staff is stressful, and that setbacks are part of the deal. Individual assessment, coaching, and follow-up are time-consuming, and they're certainly not as efficient as some of the group-based, station-based assessment that we have used previously. Australian programs, I think some of you might know, we have the advantage of some of the shortest wait times in the world, but we also have short duration of 6 to 7 weeks, and this is proving easier to convert than long programs. The longer the restrictions are in place, the more likely that some of these changes will in fact be permanent. What we're thinking is it's essential to measure outcomes from the new models, including patient satisfaction, so we can determine in a dynamic way what is the best way we can manage delivery. We have, luckily, a national minimum set of quality indicators that's ideal for the purpose. And thank you very much. Gabriella, I will finish up there.
Hello, everyone. You can hear me?
Yes, we can.
Okay. So good morning, everyone. So I want to say thank you very much for the Soberfear and the ICCPR for being invited to talk at this meeting. So, which is certainly very timely considering the strong impact from the COVID-19 in cardiovascular patients and its essential treatment called cardiac rehab around the world. So I'm going to start with a short publication history about the reality of the cardiovascular rehabilitation in Brazil. So I found the literature, the first paper published in 2008 by a former master's student who evaluated 6-7 programs. And at this point, so we started to say that it was important to be standardized and to produce some physical therapy guidelines in order to be a more standardized care. Secondly, in 2015, so we have this review that was published by Professor Randall Thomas, who look at the cardiovascular or the cardiac rehab in the South America, and they had a conclusion that the cardiac rehab is very cost effective, although they recommend that it's important to have a more affordable cardiac rehab program in order to expand the cardiac rehab. And more recently in 2019, so we have two very important publications. One, there was a award survey, and that had a participation of 30 from 75 expected programs, and they said that the quality of the cardiac rehab program around the world are very high, since they reach approximately 9 out of 11 points of the core components. And although there's a significant regional variation, which could impact the patient outcomes. And the most recent is about cardiac rehab, especially in Brazil. And they have some main important conclusion. One is that, one cardiac rehab spot is available for 99 patients, which is a very low rate. As well, that the most of the programs are funded by governmental resources. So that's an important thing. But I want to start, but actually, so I know that idea is that this meeting, it's about to present about not only the panorama, but also try to understand what is the impact of the COVID-19 on cardiovascular program. So since Friday, we've been working very hard, almost 24/7 in order to try to achieve some information and present to this webinar. And we are very happy because we have almost 50 different centers in Brazil that received our survey this last 7 days. And we're gonna present this data now. So actually we're going to present 41 centers out of 48 that responded this questionnaire. So it is kind of representing 11 from the 27 states in Brazil. The oldest program, it's from 1974. And if we summarize all the patients, so we can see that 4,384 patients are enrolled in cardiac rehab program. Although, if we compare only with the new cases of cardiac rehab cardiovascular patients that were hospitalized in 1 year before, so we see that only 0.37% of these patients were enrolled to any kind of cardiac rehab program, which is a pretty low number. So these respondents are basically, from different states from Brazil, but it's pretty much concentrated in South and Southwest area. So we don't, as we can see, we don't see many responders or many programs from the north part of Brazil. If we related this information that came for us, so we can see here on the left side, that we had, for example, a distribution from this 1 million patient. We see that, for example, that we have 275,000 hospitalizations in São Paulo area, for example, and we have 1,007 in other areas. And also, if we compare, so that's the same area where we have approximately 1,267 patients enrolled in cardiac rehab. And if we put these two numbers together, we see that, the average cardiac rehab availability in Brazil ranges from 0 to 7%. So, which is still pretty low, but it's very spread around the country. So the professionals involved in cardiac rehab programs, we have a lot of professionals involved, but it's pretty much based on physicians and physical therapy and physical educator. So, but it's a pretty much multi-professional services. So and a little bit different from what we saw previously. So we see that from this 41 services, most of them are provided by private services. We see more than 35%. Then as well, we can see, for example, that university, they play extremely important role in this area. So they provide a lot of places, for new patients to get new program rehabilitation. if we go, especially for the home-based cardiac rehab, so we see that only 21 out of the 41% of the programs offer before the COVID-19 any kind of home-based activity, and the oldest program was started in 1990. So, but basically they increase the number of the availability in 25%, because we see approximately 1,050 new patient enrolled to this modality of cardiac rehab. But on this modality per se, we see that this number compare again to the cardiovascular number of hospitalizations, it's represents something around 0.089%, which is still pretty low. So from the 41 patients, from the 41 services that was that responded our question, we see, as we can see here, so 73%, I mean, interrupt the activity during this time, and another 15% on the yellow side, we can see a reduction number of the visitings, so which impacts a lot. I mean, the number of the availability cardiac rehab program around the country. If we look at, I mean, the program policies that they've been doing in order to increase the quality of the attendance. So we see that 12 programs just started, I mean, during this period, because of the COVID-19, which is, in one hand, it's kind of a good data, because they've been forced to open, and we see that 5 program has just, I mean, expanded the home-based program. So that's a very important information. But also we see in the third information that a lot of programs are applying stuffs like job hours reduction, which is or professional activity change. So which is a very it's a very important concern. We might be aware about this. Again, if we talk about the home-based cardiac rehab, as we can see now, the number just increased for 32 centers that start to provide, increasing almost 1,000 more patients enrolled in home-based program, which represent 100 increase in home-based cardiac rehab program. Although, if we compare to the total of patients which was enrolled before the COVID-19, it was a decrease of 57%, it's pretty important to look at. Another 2 things. So we've been collecting a lot of information with this survey, but I want to present just 2 information. One, it's about safety and qualifications. So as we can see, I mean, most of the professionals don't feel safe to care patient with COVID-19 during this period. As well, if we look at the qualification, they don't. I mean, partially. I mean, 18 programs they feel kind of partially qualified to provide this kind of services, and 7 state no, so they're not, I mean, prepared to apply this kind of service during this pandemic time. And this is the second information about, I mean, the strategies the services want to see from international or from scientific associations, I mean, in order to help. So, and we see in the very bottom that 38 out of 41, they want to see some kind of scientific statement about cardiac rehab during COVID-19. 31 want to see any kind of training or education activities like we're doing today, for example. And 29, I mean, want to see some kind of app developing and helping professionals to improve their activity. From those who want to see some kind of training and education activity, another interesting information, as we can see, is that most of the programs, they rather prefer to have online scientific meetings or even a webinar like this, instead of have in-person scientific meetings as soon as possible. That's a very important information, and probably talks about, kind of a change we're going to experiment after this pandemic situation. So I can finish without saying thank you for all the frontline healthcare professionals. Please be safe, be strong, and that's my talk for today. So thank you again for inviting us.
All right, good morning, everyone. Just bear with me a second here. I'm not good with the technology, so trying to figure this out. Let's see. There we go. Excellent. Okay, I'm hoping everybody can see my screen and everybody can hear me. My name is Rob. I'm calling in from Toronto, Ontario, Canada. I want to thank the ICCPR for inviting me to this. I'm hoping to be able to share some resources at what I know is a difficult time for people all over the world. So just a little bit about our program. We're fortunate that we've got a fair bit of cardiac rehab across
Rob, sorry to interrupt. We can see the slides changing, so I don't know.
All right, let me see what I can do.
Maybe you can click enable editing on the top, and then
how's that? Can you guys see that?
Yes, now we can see changing.
Okay, I'm just going to keep it
Sorry
in like
to
this.
interrupt. Thank you.
No, that's fine. That's fine. That's fine. So where was I? So we are one of a number of cardiac rehab programs in Canada. We're very lucky here that we do have a fair bit of access to cardiac rehab. So I'm going to speak specifically about my program here. We've got different programs in the country, have got different access to resources, and they've had different results in terms of what they're able to do. So my experiences are just going to be within our program. We do have one of the larger programs in the country. We see upwards of about 2,000 people per year at 2 sites. We have one site in the north part of the city. We see about 1,600 people here at a purpose-built facility. We have 2 wonderful exercise tracks that we can use, a lot of home exercise equipment, a dedicated education theater. Our second program is a hospital-based program more towards the downtown core of our city of Toronto, which is about 3-4 million people population-wise, and they see about 400 people, largely on an exercise equipment-based program. At any one time on our program, we have about 1,000 patients coming in actively. Our program is 6 months in duration for most of our patients. Our sister program downtown is only 4 months long. Both of the programs rely heavily on weekly on-site visits. So we see our patients coming in every week for 4 to 6 months for a 90-minute visit. That 90-minute visit is a combination of about 30 minutes of education and up to 60 minutes of exercise, usually cardio and or resistance training. Managing those 2,000 people per year, we have about 14 full-time equivalents of case managers, which come from a variety of disciplines. Most of them are kinesiologists, but we do have physiotherapists here. In the past, we've had occupational therapists and nurses. Even though they have different degrees, their function as a case manager and the responsibilities is the same across the board. In terms of timelines in relations to the COVID pandemic that everyone is dealing with, our center was closed to on-site care on March 16th as part of restrictions across pretty much the entire country. And I'm sure other people can relate to that as well. During that time, we suspended all the on-site visits, and we spent about a week calling our patients to say that we were going to be closed to on-site care for the foreseeable future, but we had a plan to continue to provide cardiac rehab virtually. So we were planning on calling all 1,000 of those patients on a weekly basis and just continuing to support them with their cardiac rehab journey. So what we ended up doing is we took a look at the amounts of employees that we had, the number of patients that we were planning on supporting during this crisis, did a little bit of math, and we determined that each one of our care providers would be allotted about 20 minutes to make a phone call to each one of their patients. During that phone call, they're providing exercise supports, strategies on how you can maintain a heart-healthy, active lifestyle while you're being physically isolated. So instead of a 2-mile walk through the park, how do you move that to home-based activity? And then we were also sharing our online education program that we have, which is very robust, and that's going to be the focus of the next 7 minutes of my talk. For newly enrolled patients, we did give our staff about 30 minutes to deal with them. The established patients already knew how to check heart rates, knew how far they had to walk, and had a significant amount of education about a heart-healthy lifestyle. New patients, unfortunately, didn't have all of this opportunity, so we gave our staff a little bit more time, knowing that those phone calls would be a little bit longer. So that's about us. I don't want to talk too much about the restrictions because I know we have an international audience here, and I'm sure all of us have got our own unique restrictions and challenges. So what I'd like to do is I'd like to share a resource that is freely available for anybody in the world. All you really need is access to the internet. So we have a wonderful online presence. I know that Robyn from Australia had mentioned during her segment, I believe they're using it there. Anyone can access this. As I said, all you need is an internet. Our address is www.healtheuniversity.ca. And what we have is we have a platform with a significant amount of education that focuses on heart-healthy living for patients that have got cardiovascular disease via our cardiac college site, or diabetes with our diabetes college site. The content that we have in here is quite holistic and quite broad. You can see here we've got some main headings which talks about treating heart disease, getting active, talks a little bit about nutrition. We go into emotional health and well-being. We talk a little bit about the importance in cardiovascular rehab of taking control. And then we also have what's called our Thrive 12-week challenge. So just sharing a little bit of this information. On this page, about halfway down, we've got a downloadable PDF. So if patients want their workbooks, we've got quite a large workbook with many different chapters in it. I'll show you what some of them are shortly. We also have good resources in terms of exercise programming. I know that myself and my colleagues, when we're reaching out to our patients and encouraging them to remain active, when we discuss resistance training, that becomes quite challenging. It's quite easy to tell somebody to maybe march on the spot for 10, 15, 20 minutes, or if they're young enough and they live in a quiet area that they can still get outside and remain socially and physically isolated. But showing them how to do a variety of resistance training exercises is quite difficult to do verbally over the phone. So this is a wonderful resource that we've been sharing with people. It's our resistance training video gallery. We've got a lot of information on how to do resistance training safely, definitions of terms, and then we also have short little videos on how to do all these little exercises. So we can select, for example, maybe we want a patient to do a half squat just to improve leg strength, cardiovascular conditioning a little bit, depending on how much they do. So we can just say, go to the video that's half squat without dumbbells, and they'll be able to watch that at home in the comfort of their own place. We also have another resource just to try and help our patients stay motivated. Got that circled here on the right of the screen. It's called our Thrive 12-Week Challenge. This is a series of 5-minute videos that people can log in and watch that cover a variety of heart healthy topics. One of the concerns that we had with our patients is when we first had COVID-19 and people were locked in their homes, we found the first couple of weeks were just kind of shock and awe. Can you believe this is happening? Oh my God, it's going throughout the entire world. What am I going to do? And a lot of people were not really thinking so much about doing exercise. But now that we're going into our 5th week of being shut down, people are really starting to think, okay, I need to make sure that I look after my health. And motivation to do that is becoming quite a challenge. So these little Thrive videos are things that our clinical team is using to help patients be motivated. We've got a nice little section on goal setting where people can choose a heart healthy goal, follow a few steps to try and reach that heart healthy goal. And then our clinical team in the following week's phone call might be able to see, well, how far did you get? Did you complete that goal? If not, what were some of the problems? How can we problem solve to try and help you achieve those? So this is another wonderful resource that we're seeing an awful lot of uptake on. This is a breakdown version of that downloadable guide that I said. There's a fair bit of education here that's designed into a number of different aspects of cardiac rehab, whether it's just some basic information on how your heart works, what some common procedures are. Have you had a coronary artery stenting procedure or coronary artery bypass? So some basic information on that. A little bit on heart medications, what to do with symptoms. So it's quite a robust guide of information that patients can take a look at. It's designed to be for the lay person. So this is not so much for clinical support, but more for patients to take a look so they can help with their health knowledge, which we all know is quite important. And we're also doing our best to try and translate this into multiple languages. So right now we have this guide available in French, Spanish, Portuguese, Punjabi, and Hindi. We're in the process of trying to translate this into other languages. And as those resources become available, we will upload them onto this website. It's quite an involved process for us, only because there is a great deal of content and information. We want to make sure that when we do the translation that we're getting it right. So having it all proofread and everything like that is something we take seriously, and it is resource intensive, but we're working on trying to get this out to everybody. So I know for a lot of programs out there, you might not have the same kind of resources that we do. Please, this is a resource that we're happy to share with anybody in the world, and there is absolutely no cost to you to do so. All you need is a computer and an internet connection, and we're very, very happy for people to use it. If you have any questions or concerns about accessing the resources or anything like that, Gabriella will share my contact information, and I'll get you in touch with Crystal Altman, who maintains this site, and she's wonderful, very, very reachable and available, and she'll do what she can to help people access and solve any problems that you might have. Finally, just a little bit of a plug for another thing that we're doing to try and engage with our patients. 4 days per week, we're using a Zoom broadcast. We've got a variety of healthcare providers that are doing short 30-minute sessions to ideally our patients that are actively in the program, but just like our resource guide, it's available globally. And we're noticing that some patients are coming in from Asia, from the UK, from the States, and they're catching these live streams as well. Information for this is available off of our Cardiac College website, which is accessible off of Healthy University. And just real quick, because I know I've spoken for my 10 minutes, I'm sorry, Gabriella, just a few things that we've learned that I'd like to share in the last 4 weeks. A lot of our staff are finding these phone calls to be emotionally draining. A lot of patients are socially isolated and their usual support networks are non-existent and quite broken. A lot of our discussions are not necessarily around how to do your exercise, but it's just providing contact for patients. So it's hard. Look after your providers. It's challenging to do that. For many people, we really need to think outside the box on how to provide exercise. The basics are there. Provide support. Try and get people moving as best you can. We're not able to provide, for many of us, cardiac rehab the way we normally do. That's okay. We're still able to provide an awful lot, and that's a very, very valuable and important service. So think outside the box on what things you can do, as opposed to focusing on barriers and things that you can't do. We've gotten a lot of wonderful feedback from our patients. They're very, very grateful, and they share that with us. So it's rewarding, which is good. And the other thing that we are starting to do here is it was one thing to continue to provide support to patients that are actively on the program. Starting new patients in the program is something that's been challenging for us. We have quite an involved intake process with a lot of screening prior to enrolling patients into the program. And this has been turned entirely on its ear. So we're thinking outside the box, and we hope in the next 2 to 3 weeks to be able to start enrolling brand new patients, because this COVID thing could potentially be going for weeks, if not months longer. And unfortunately, heart disease continues during that time. People need a quick access to cardiac rehab. We know that improves outcomes. So we got to make sure that these people are not forgotten and we look after their health. And at that point, I'm going to end. Once again, thank you, everyone. Stay strong to all my brothers and sisters in the cardiac rehab community. Keep doing the good work that all of you are doing. Thank you very much.
Thank you so much, Rob. And thanks, Gerson and Robyn, for the great presentations. I'm gonna go quickly and share my screen now for the next 3 presenters. So we have now Dr. Aashish Contractor from India. He's the Director of Rehabilitation and Sports Medicine at the Sir H.N. Reliance Foundation Hospital in Mumbai, India. And he's the past head of Department of Preventive Cardiology and Rehabilitation at the Asian Heart Institute. We have Dr. Tee Joo Yeo. I hope I pronounced it correct, TJ, sorry. He's the Director of Cardiac Rehabilitation Unit at the National University Heart Center in Singapore. And also he's a committee member at the Singapore Heart Foundation. And finally, for this second block, we have Jacqueline Cliff. She's a cardiac rehabilitation nurse lead at the BCUHB in Wales, UK. So I will open Aashish's presentation. I don't know if
Yes, thank you so much, Gabriela. Are you able to hear me well?
Yes, I am.
Can I share my video or is that stopped?
I don't know. I don't know how to do that. Sorry.
Good evening, good morning, good night to people in different parts of the globe. Hope everybody is doing well and staying safe during these times. I'm just going to give you a very quick background on what's kind of happening in India. Next slide, please, Gabriela. Mm-hmm. So just this morning, these are statistics of our official health website, which are 17,000 cases in India and 718 deaths. Obviously, each death means a lot to people around, but for a country of 1.4 billion people, this is a relatively low number, and our fingers are crossed. We had a nationwide lockdown, which started on the 25th of March. So it's exactly a month. And our lockdown is, in a way, very different from most countries where it was an absolute lockdown. So people were or are not allowed to step out of their house for anything except for essentials like grocery shopping or having to go to the hospital. Next, please. So what I'm going to do over the next 5 minutes is just give you an overview of what's kind of going on in our program. So since we closed, we've started tele-rehab, and that's not a very common thing in our country. So on a typical day in our program, we see about 60 patients a day in cardiopulmonary, and we also combined it with an oncology program. So we got a cardiopulmonary oncology program, and we see about 60 patients a day. And over the last month, we've seen about 47 different patients. So on a given day, we are seeing somewhere between 20 to 25 patients. Next, please. Our goal essentially at this time is to prevent a decline in their physical activity level. So we're going to try and maintain them where they are, to try and avoid weight gain because everybody's stuck at home and there's very little physical activity, and to continue their rehab to get their benefits. One big challenge for all of us in Mumbai, it's a big and crowded city, and most people live in tiny apartment blocks. So it's not like they have a lot of place to exercise or they have individual houses with yards. So that's a limitation with which we need to deal with. Next, please. In terms of the platforms used, the largest internet provider in India is a company called Jio. So we're using their platform. It's called the Jio Meet. It's an app, or sometimes we also use a WhatsApp video call. We have our patients, we divide them into groups based kind of on their health and fitness levels and their conditions. So we kind of have the cardiacs together, pulmonaries together, and the oncology patients together. And the groups are typically between 3 to 5 patients at a time. Next, please. So in terms of the principles, I'm not going to really spend any time on this because this is something we all know. We use the FIT principle. And as you can see the little picture, we have our staff sits with a laptop, and on the other end, you have between 3 and 4 patients who we are actively monitoring real time. Next, please. So in that 30 to 35 minutes that we spend with the patient, we spend the first 5 to 10 minutes just on breathing, warm up, some flexibility exercises, the next 10 or 15 minutes on some aerobic exercise, and we finish up with strength training. In addition, we ask the patients off call, which means on their own, to walk somewhere between 10 and 60 minutes during the day, depending on their physical condition. Next, please. So in terms of strength training, we improvise. We have people lifting water bottles at home. So a 1 liter water bottle becomes a 1 kilo weight. A 2 liter water bottle becomes a 2 kilo weight. So we need to improvise. We have people lifting different grocery bags, things like that, to substitute for weights because most people do not have a home gym. Next, please. We're also trying to be innovative and looking at various apps. So there is a Pacer app which measures the distance and steps. So what we did early on in this week is to actually try and see if we can do a 6-minute walk test based at home. And we actually found it quite interesting, and we could do that. And I'll show you those results. Next, please, Gabriella. Look, so sorry. So before I go there, in terms of assessment, we use the FACIT scale for the quality of life for the cancer patients. For cardiac, we use SF-36, and we use the St. George's scale for the pulmonary patients. So we send them an image format of the scale. We ask them to mark it, and they send it back to us. So we're trying to replicate real life as much as is practically possible. Next, please. Yeah, so the Pacer app, what it does is it measures the distance, and this week we compared it with some of their previous results. Next, please. So just look at the, actually I think the final part of this slide has been cut off, the lower half, but essentially what I wanted to show you in this slide is that the 6-minute walk test that we did on the patients before they discontinued the program and after they started the home program is not too different. So hopefully that shows two things. There's a reasonable degree of accuracy in this test, and hopefully it also shows that patients haven't lost too much of their fitness during the lockdown period. Next, please. So we're also using technology. There's a company called Frontier X. And actually what I wanted to do, my video is not on, is wanted to show you live streaming ECG. So what this does is we put a strap around the patient's chest, very similar to a Garmin strap or a polar heart rate monitor. And we get a live single lead ECG going, in which we can look at arrhythmias, and we can also look at ST changes. So this is actually a game changer because it's very inexpensive. We managed to send one to the patient. The patient puts it around the chest. It's very convenient to put, and they get going. So we get live ECG streaming, which I think is very beneficial for people who are just started new in the program. Next, please. Yeah, this is just a close-up of that. Next, please. So just quickly going through some of the barriers. One is the cost. So sometimes a lot of patients are self-pay, so they find it hard that, okay, if they're not coming in, should they be paying the same amount of money? So for some people who cannot afford it, we have done a program where they pay half the cost for the same number of sessions. Often the quality of the video call may not be quite as good depending on data connectivity, and there are call drops. Some patients feel it's not the same thing as being in person. Most people don't have gym equipment at home, so that's definitely a challenge. And some of them are older and they're uncomfortable using technology. So we found that approximately 50 to 60% of our patients who were with us prior to the lockdown have continued in the program. So that's pretty good, and we hope to scale it up in the coming weeks. Next, please. Limitations, of course, you cannot physically assess the person. So we have them have their blood pressure monitored. Those who have diabetes, we get their glucose monitored at home. But some of the other physical assessments, we're not able to do it in person. The reliabilities of the apps that we are using, we are trusting their accuracy, and those really need to be proven in randomized controlled trials, which many of them haven't been as yet. Next, please. So this is the last slide. I just wanted to add what actually Rob said in his last slide, and I echo that. 2 or 3 things which I thought were very important, what he mentioned, and I completely agree with that. The first was that we need to take care of ourselves as well. As they say in the airline, when the oxygen level is low, make sure you wear your own mask first and then put it onto the person next to you. So I think healthcare providers need to take care. As part of our program, we also have mental health for all our patients. We have yoga sessions. We started doing live yoga sessions. We have our psychologists call the patient as per their schedule, which is typically once a week. We also have our psychologists talking to our own health workers to make sure they are remaining mentally and physically healthy during this time. We also need to think outside the box, as Rob said, and he ended by saying that the patients were very grateful that we were reaching out to them in these difficult times. And I completely echo that. Our patients feel the same way. So thank you very much, Gabriella, for helping out with this. Stay healthy and stay safe, everyone. And I want to thank my colleague, Dr. Jenny Patel, who's on the call, for making these slides as well. So thank you, everybody, and stay well. That's it for my presentation. Gabriella, looking forward to TJ's presentation from Singapore.
Thank you. Perfect.
Okay, hi everyone. My name is Tee Joo. Can everyone hear me?
Yes.
See my screen?
Yes.
Okay, thanks, Gabriella. So I appreciate the invitation to be part of this very important initiative, and to be able to share my country's experience with everyone. So I had the cardiac rehab unit in Singapore. My unit is called the National University Heart Center, and I did my fellowship training in Toronto, where Rob was, and that's how I got to know Rob and Gabriella and many of the other esteemed cardiac rehab providers. So let's just start off with yes, the situation for cardiac rehab in Singapore pre-COVID. So Singapore is a very tiny nation in Southeast Asia. We have a population of only about 5.6 million. In terms of land area, we are just slightly larger than Toronto, so we are really very small. We are also just about 5 hours away from Australia. So our cardiac rehab programs are largely helmed by the government restructured hospitals, as well as a standalone outpatient ambulatory service. In total, we have about 7 programs. And the first program began way back in 1979. On average, each program lasts around 7 weeks. So this is for a hospital-based program, where patients come in twice a week and take part for 80 minutes per session. As part of the international or global survey that we did together with ICCPR, as you can see published in eClinical Medicine, our participation rate was actually quite poor. Only 15% of eligible patients took up cardiac rehab. And when we translate that into actual numbers for eligible patients with ischemic heart disease, that gives us more than 14,000 eligible patients who do not receive cardiac rehab per year. And this is pre-COVID. So we can imagine that now with all the social distancing and people who even want to come to cardiac rehab, they can't. That gives us a lot more headache. Here's a short timeline of the pandemic situation in Singapore. So our very first case was diagnosed on the 23rd of January. And we actually managed to keep our numbers down for almost 2 months. And we even received quite a lot of praise from the international arena, from WHO. But then things started to deteriorate. First, we had our second wave of people because we were calling our residents back from other countries. So the imported cases gave us a second wave. And more recently, we have a significant exponential rise in cases due to the community spread of COVID-19 within our migrant workers. So as of today, we have 12,000. We have exceeded 12,000 number. And just to take a slightly lighthearted take on the matter is that, you know, with all the lockdown measures, Singaporeans really love our food. So when McDonald's actually shut down completely, we were devastated. And a few days later, when our beloved bubble tea outlets were also completely shut down, that really makes things very bad. Thankfully, we have a small country in Europe, Switzerland, that has showed solidarity to us, and they have projected our country flag onto the Matterhorn, as you can see in the middle picture over here. So Singapore shares a lot of traits together with Switzerland being a small multi-ethnic country. So it's a very, very meaningful gesture. Okay, now this I wanted to bring your attention to this article that I wrote with 2 of my fellow colleagues, and it was inspired by a real patient who basically, once our exercise classes were stopped, he sent a very strongly worded email straight to senior management, pleading for his rehab class not to be stopped. And that basically triggered a lot of thoughts in how we could actually utilize technology and other means to deliver cardiac rehab in an effective way so as not to neglect our patients. So of course, with every new development, with every new program, there are various challenges faced. I will touch on this briefly. Not sure how many of my fellow panelists in the countries have faced these challenges as well, but I've broken them down to a few topics. So firstly, the patients themselves. The existing patients are sometimes left in the lurch because out of nowhere, the classes are suspended, and they used to come in for exercise classes 2-3 times a week, and now they can't, like what the patient did when he sent the email to senior management. And in Singapore, unfortunately, we do not have any alternatives readily available. So tele-rehab is not a standard of care in Singapore. We only have traditional cardiac rehab. So as such, we we have to actually come up with our own new guidelines on our own, and this is actually challenging. Next, our patients span a wide spectrum of socioeconomic status. We have those who are very well-to-do, very well-connected, very tech-savvy, who have no problems using smartphones, wearable gadgets, ECG monitors, etc. But then a large majority of the patients are also of the lower socioeconomic status. They range from the migrant workers that I mentioned earlier on to elderly patients with very few caregivers who are not tech savvy. They do not know how to access the internet. They do not have a smartphone. So we have to think of ways to be able to engage this population. Next, our cardiac rehab staff. With the sudden lockdown, many of them have been redeployed or require change of roles. Some come from neighboring countries like Malaysia, which also has imposed their own lockdown, and they cannot even come over to Singapore because there was no lead time for preparation. So they are basically stuck in their country. Even though they work in Singapore, they are unable to leave the country for that. And because unfortunately cardiac rehab has been deemed a non-essential service, I'm not sure if any of the other panelists are facing that as well, but the cardiac rehab nurses have had to work from home. Of course, this is for their own protection to reduce the chance of infection, but that is a great barrier to our usual work when we see patients face to face. And for the technology challenges, basically in Singapore, we're quite unique because a few years ago, our major healthcare cluster was the subject of a hacker, and many thousands of healthcare identities were actually hacked, and this led to internet separation in all the restructured hospitals. This means that there are no widespread internet terminals in the hospital, only selected like maybe one per department or one per floor, that kind of thing. In other words, we can only use intranet, and that creates a lot of barriers when we want to connect with patients using the internet. And in terms of security-wise, recently one of our, Zoom, of course, has been mentioned by many panelists as a very good source of a video conferencing platform. But recently, in one of the home-based learning for our secondary school students, the platform was actually abused to show offensive images. So we're very concerned about security and privacy as well. And of course, from the ops and admin point of view, we've had to scramble to revamp our website to try and put together resources. I think we still have a long way to go before we can reach the standard of UHN, which is, to me, is the gold standard. And we also need to develop new billing schemes. In Singapore, cardiac rehab is not paid by insurance, so there is out-of-pocket cost to the patient. And if we were to use tele-rehab, we would have to actually find a billing method that is acceptable to the hospital as well. So these are the barriers that I've mentioned, and these are the challenges. And of course, we have to try and see whether technology can help to bridge this gap. I was very heartened that 2 weeks ago, the Caring Heart Support Group, which is comprised of patients who have been through cardiac rehab, they invited me for their very first virtual gathering. Now, this one was very impressive because they are self-sufficient. They did not require any help from the hospital, but due to very enthusiastic leaders, they actually managed to put together a virtual teleconference and did group exercise together, etc. So this shows you that where there's a will, there's a way, and we can actually make this happen. So from hospital point of view, we started from scratch. We looked at all the challenges we are facing, and we took things step by step in terms of level of technology. So going back to the old voice communication with telephone, that was our mainstay. Of course, my team has been working very, very hard to communicate the suspension of exercise classes to all our patients, to try and keep in touch with them and find out how they are doing. And we also decided to use text messaging, so the short message service SMS, to replace our face-to-face inpatient counseling, which is also called Phase 1. And the screenshot you see at the bottom is an example of the set of 3 text messages that we send for all our inpatients admitted with myocardial infarction. So it says that, I'm a heart rehab nurse, and we'll send you a link to a patient guide. And this link has been shortened so that it doesn't take up too much characters. Patients with smartphones can click directly on the link, and that will take them to our in-house educational booklet on coronary angiogram and angioplasty. We also tell them which page to refer to for post-discharge advice. And finally, this message actually includes a phone number for patients to call for Phase 1 counseling by voice. This we have just rolled out not too long ago, and the uptake is still, small. It's 23% so far, but we are hopeful that as we iron out the kinks, things will get better. Next, the low-lying fruit, so to speak, we are trying to consolidate existing resources that we already have into something that patients can access easily, and this is in the form of a website. And also, we are trying to actually convert our educational sessions into pre-recorded videos for patients to click and listen at their own time. Of course, this will take more resources and will take up some time. Finally, for video conferencing, we acknowledge that there's nothing that beats seeing patients face-to-face, but video conferencing is a very attractive way to go. With all the challenges that I mentioned earlier, this will take some time. So we are putting that at the back of our minds, but focusing our energies on the rest first. So quickly to share what kind of resources I was talking about, we have in-house produced various educational material that you can download freely, of course, same as Toronto UHN. So it's under www.nuhcs.com.sg. And we also have our own YouTube page, which features various videos on various conditions, various procedures. Not only that, we are hoping to include the rest of very valuable resources from Singapore. 3 large sources. Firstly, the Singapore Heart Foundation, which is also a member of the ICCPR. So they've produced various videos. It started off as a Facebook Live video to engage the patients, and they've put it up as a permanent video on YouTube. Next, the Ministry of Health runs this website called the Health Hub, and it's a wealth of information on various cardiovascular, chronic disease management, exercise advice. The Health Promotion Board, also a subset of the Ministry of Health, also has a YouTube channel. If you can see, I don't know whether it's too small, there are various playlists for different categories of patients. For those who are a bit more frail or older, they can always click the easy exercises for seniors. It comes in our 4 national languages. And for those who are a little bit, more energetic or higher baseline fitness, they can choose a slightly more intense activity. So with that, come to the end of my presentation. I'd like to acknowledge my entire cardiac rehab team. I think many of them are also listening to the lecture, so I'm grateful to each and every one of them for putting in all the efforts during this period of time to help our patients. And like what Rob said previously, also hope everyone has to take care of our own health as healthcare providers. And with that, thank you for your attention.
Thank you. Our next presenter is Jacqueline Cliff.
Hi everybody, I'm Jackie Cliff, and for some reason we stuck on one slide, so I'm just going to have a little fiddle with that. Thank you very much for inviting me here today. And please don't tell my mum that I can talk to people across the world, because she'll be on the phone saying, why can't you pick up the phone and talk to me? So let me just sort this one out here, and we will be with you in a short while. Sorry about that.
Jacqueline, we cannot see your screen.
No, I'm just trying to
okay.
upload this.
If not, I have your slides open, so if you want, I can share my screen and you can let me know when to move, if you prefer.
Yeah, mine were there and they've just disappeared. So if you don't mind sharing yours, that would be great. Thank you.
Okay.
So by the sound of it, there's an awful lot of similarities between what's happening over here in the UK and what's happening over in over the rest of the world, which is very interesting. What I wanted to just introduce myself as Jacqueline Cliff, the lead nurse for the cardiac rehab team over in North East Wales. And that's in a small part of the UK. We've got a 300,000 population area for our own area. On my first slide there, we've got our British Association for Cardiovascular Prevention and Rehabilitation, the core standards and components. So I've based my, we've based our changes really over these main standards that refer to the actual recruitment, assessment, delivery and end assessment of our patients. And most of you will be familiar with the type of process that we involve with this. So this is very much a presentation about the hands-on ground level care. I'm going to look at the adaptations and prioritising that we've put in place, the impact of each of those things on these 4 standards here, specific considerations on the interventions that we've put in place, and lastly to look at the support out there for us as cardiac rehab team members to help patients, and also out there for people who have got heart issues. Next slide, please. Gabrielle, we've got, oh, there we are. So this is a very busy slide, I'm afraid. So it's just really to demonstrate the various colours do refer to the various standards. And at the very top, we had to very quickly identify which patients we were able to see, because like many others that we've spoken to and heard about from today, suddenly we weren't able to see people face to face. So, and also some of our staff, we knew that they would be redeployed, so it was very quickly hands on deck to try and look at how we can manage this situation very quickly. So what I'm going to do is talk about the way that we prioritised those patients in the first place, so that we would have the people that were we'd categorise as green for go. We're going to be speaking to those people, and they were people that we felt were in more need, and we then sort of looked at the sort of amber area, people that, well, if we're not able to provide the same service, is there something that we could do to encourage people to come along, but not be overly creative about trying to invite them? That sounds quite crude really, but we knew that we would only have a certain amount of time to be able to support people. And then in red, these are the people that we said, no, we're not able to provide a service for these people at the moment. So people who have stable angina that can cope quite well with the current medications, and also people with stable heart failure. We have got a fantastic heart failure team, and we knew that those with unstable heart failure and needing care in that way would be looking after those. Down at the bottom there in the purple, that's another area that I will be concentrating on in a little while. Next slide, please, Gabriella. So here's our priority list. And much of this took place while I was away on holiday over the phone with my staff, who pulled together extremely well. Priority A are unstable type of patients, people who are at high risk of being readmitted, and also people that perhaps really needed to be readmitted. And those were people who were new following acute coronary syndrome, plus or minus angioplasty, heart surgery, people who have type 2 MIs, Takasubos. These people often have lots of questions, lots of chest pain, wanting to call 999 or emergency services, or go to emergency departments. And also people like those who have symptoms. And included in the symptoms, we have put symptom anxiety, because again, people have a lot of symptom anxiety, where actually when they are aware that there is no big need to be anxious, they're calm, the symptoms they understand are perhaps not cardiac, they can manage those very well. So our aim for those, keep them safe, keep them away from the emergency services, help them to maintain their own shielding. And we knew that they required good support from our skilled cardiac rehab staff, and some of those they may well require our advanced practitioners and non-medical prescribers. Category B were their stable patients, those that had already been in our service, and they were the recovering and progressing patients, people who needed that ongoing support. So we were giving telephone conversations to these people, and also trying to help prevent post-event complications that could arise, how to access care, how to look after themselves. And with our elective PCIs, we were inviting them by letter, knowing that some of those people were absolutely fine and wouldn't contact us, and those that did need our support would ring us. For these people, it was about trying to keep them from becoming a Category A patient, being able to discharge them out safely when they were ready. Again, requiring skilled cardiac rehab staff, may require a nurse prescriber or an advanced practitioner who could support their ongoing care. And then we have our Cs. I expect a lot of your services out there had a lot of people phoning. What do I do? Do I have to stay away? What about my work? Am I allowed to go to work? I had a heart attack 2 years ago. So there were lots and lots of questions, and it was trying to feel them out. And we appreciated that those people could problem solve themselves if they could know what sites to access, what to have a look for. And again, our admin staff were fantastic, being able to speak to those people. Next slide, please. Thank you. So here we are back in our standards. So what did we find with recruitment? Actually, we found a lot less people, like you said, have been presenting with acute coronary syndrome, and BHF Cymru Wales have said that there has been a drop of 20% drop in people attending hospitals or emergency departments in Wales, and in England it's being quoted as a 50% drop. So where are those people? Obviously, like yourselves, because of the COVID, we've not had routine surgeries, routine interventions. So actually, we've not had those people coming to our doors. But what we have had are more people with angina, because they're waiting for their heart bypass surgery. And in the meantime, they need our help. Looking at the assessment, we've been able to perform those functional exercise assessments that help us to know that those people are going to be safe doing those exercises. We've not been able to do a 12-lead ECG, pulse, blood pressure. We've not been able to put hands on and clinically examine those people. So some patients have had their own blood pressure machines, and that's helped us to a degree. Then when we're thinking about the delivery of care, we've still got a little way to go in terms of being able to get our group exercise sessions as individuals supported by ourselves. We're doing some of that. We've got access to some online videos, which is fantastic. And it's just being able to tailor those to the right kind of patient. Again, when we're thinking about the testing, people don't want to leave their homes, people don't want to go for blood tests, and also where blood tests could be done, they've not been able to access them. So from our medical point of view, the provision that we provide from cardiac rehab, it's been very difficult to work out who we can do that medical prescribing for, and for those that we've said we'll have to wait. We're wondering how that's going to have a knock-on effect with the patient's prognosis. And then we've got the end assessment. We will be wondering which patients we can refer back on to the community doctor for management of their ongoing long-term cardiovascular health. We've got people who will need to come along to an exercise program at some stage, or then to start with the National Exercise Referral Scheme, which is a service that takes place after our cardiac rehab program. So we've got a few considerations alongside these standards. Next slide, please. Very specifically, the next two slides just mention things that we've noticed. And I've mentioned blood tests. When do we do them? What's the best option? Can we get them done when they're having another blood test? We want to keep their kidneys safe, so sometimes we've had to hold off on some medications. Again, some 12-lead ECGs need to be done for symptoms or for risk assessment, echocardiograms. Some are being done in hospitals, some we're having to leave and look at in our post-intervention medical management service later on. Next slide, please. And of course, like I've mentioned, up titration of those needed cardiovascular medicines that some of our team would be doing, particularly for moderate to severe LVSD. Our service has tried to, where we can, offer some parts of that facility. And if we can't, we're going to be doing that later. Low to normal LVSD, we're going to be leaving for our GPs, community doctors, perhaps with some good recommendations from ourselves. We're finding that we're writing a few prescriptions for anti-anginal medications. And as for statins and lipids, that's going to be waiting for another day until things are settled. Last slide, please. So what I wanted to draw your attention to is that we're very grateful to the British Heart Foundation, fantastic website, lots of things on there, particularly for patients, very good for health professionals also, and we've been directing our patients to that. We've also been using some online cardiac do-it-yourself manuals at home. So the heart manual is one that we're using. Activate Your Heart. I know that other cardiac rehab services are using those. And there is also the Reach Heart Failure Project for people who've got heart failure and want cardiac rehabilitation. We've not started using that at the moment, like I said. But they are some very good resources. Canada, by the sound of it, have got some fantastic resources that we'll certainly be looking at as well. So I think this sudden situation has brought a lot of rush, a lot of panic, a lot of worry, a lot of concern for the immediate, but also the worry for how those people, our patients, are going to be for the long term. Are we going to see a lot more heart failure patients? Can we use these resources to try and help prevent that from being a problem? And it's also about, like we know, keeping our own staff safe, and I'm very grateful to them for their input in providing the information for this this talk today. That's the end of my talk. Thank you very much, Gabriella, and everybody.
Thank you, Jacqueline. I know we are almost 9:30, but we still have 2 more presentations, and if you're able, please stick with us. The presentations have been amazing, lots of great information. So we have now 2 more presentations from Latin America. One is from Dr. Daniel Quesada. He's a cardiologist and the head chief of the Department of Cardiology at the Hospital San Vicente de Paul in Costa Rica. He's also the coordinator of CR program and the president of Costa Rican Association of Cardiology. And then the Colombia team, we have 2 presenters from the Colombia team, Dr. Claudia Santos and Dr. Monica Rincon. Dr. Claudia is a cardiologist, director of the Servicio of Cardiologia Mediagnóstica TecMedi in Bogotá, Colombia. And Monica, Dr. Monica, she's the chief of the Department of Physical Medicine and Rehabilitation Foundation, Cardio Infantil Instituto de Cardiologia, also in Colombia. Okay, so please, Dr. Daniel, you can start your presentation.
Okay, good morning. Can you hear me?
Yes, we can. Perfectly.
Okay, great. Okay, let me share my presentation. Okay, I hope you can see it.
Yes, it's perfect.
Thank you very much, Gabriela, for inviting us, and thank you all for still being part of this presentation. For us in Costa Rica, a very small country, it's an honor to be part of this experience and share all of our challenges and our problems in this pandemic. So I will talk a few minutes about how things are done in Costa Rica. To put in context, our country is a small country, 51,000 kilometers, 5 million people, with 20,000 GDP per capita. Almost 70% of our health is provided by the public system. We have a very robust public system in terms of coverage for the people, with of course some of limitations in some parts of the economics. So almost 80% of the people are covered by this public system. We have also a private system that covers part of the population, and some people use both systems. Almost 10% of the money of the country is invested in health and in this public system. And we have an 80 years life expectancy, probably one of our blue zone in some part of near the coast in Costa Rica that it's there. So this is our country. This is the map of our country. Highlighted are the places that do cardiac rehab. As you can see, unfortunately, most of the places are located in the center of the country. The center of the country gathers more like 60–70% of all the Costa Rican population. So we have some kind of a challenge there to give cardiac rehab to places that are near the coast and some places in the province that is far from the center. All of these centers, the first we are writing here is the public system, and the last one is a private cardiac rehab program. This is our hospital. This is where I work. It's called San Vicente de Paul, and this is what we call the gym. That is where we do the cardiac rehab program. So our program started in 1984. It has a cardiac rehab and primary prevention program. It's a multidisciplinary and a 6 months duration. One of the challenges we have is the time patients have to wait for the assistance or for the initiation of the program. As you might imagine, a mostly public system with some of limited resources. sometimes we cannot attend the patients as soon as we would like to. Of course, cardiovascular disease is the first cause of death in our country and also in our province. In our program, we have a mean age of 60 years. 70% are males. 55% have had a previous PCI. And the groups are made of 10 patients, excuse me, per hour, with sessions 3 times a week for phase 2 and 2 times a week for phase 3. So this is the situation for the COVID-19 epidemics in Costa Rica. So far, we have 681 cases, 180 recover, and 6 deaths. So our first patient was on the 6th of March. It was a colleague, obstetrician. Unfortunately, he passed away for the infection. And somehow we have handled it to make not so many cases. The graph is that I'm showing down is the new cases we have had. Since the beginning, we had started with quarantine, gradually limiting the space movement and social distancing. So far, we believe, fingers crossed, things are not overwhelming our health system. Some of the things our country has done for the patients is the home medications delivery for the drugs and the prescription we provided, made by the institution that is Caja Costarricense del Seguro Social, that is the public system, but also other public and private institutions had joined this effort to give medication for the people at their homes, so they don't have to move, like universities, the post system, and also private companies like Rent-A-Car have also helped in this way. We also are working in developing of convalescent serum in one of the institutes in our country, that it is Cloromido Picado. They used to do usually snake venom antidotes, and now they're working on that. And one of the major changes we have in terms of rehabilitation is that one of the main rehabilitation centers in our country, it's called Senare, was turned out into a COVID facility to project to attend almost 90 patients with COVID infection. So far, fortunately, we have not used that center much, but it have canceled all the rehabilitation they do there, including cardiac rehab. So at that center, they have all turned into virtual sessions, impacting very badly this thing, but it was a decision made preventing some kind of overwhelming in our public system and in our health system. So in our daily practice, all elective procedures were canceled. Only qualified emergencies are accepted, and our regular cardiac rehab stopped since March 17. We have divided our cardiac service in teams, so try not to be at the same time and the same place. We only have 4 cardiologists in our hospital, so besides cardiac rehab, we have to attend all the other things of cardiology, acute coronary syndrome, heart failure. So we have divided our work, trying not to expose every day us to possibly or suspected COVID patients. And for the regular appointments, we are doing it by phone, doing digital receipts, and as I told you before, and the appointment generation also do it digitally. So for the cardiac rehab, this is some examples of what we have done, not only in our hospital, but also in our country. all of the other centers that I included before had changed it, as many of you have also done, to Zoom to do interactive virtual sessions. Most of the sessions are done twice a week or once a week, 1 hour session, trying to do exercises, what people can do in their houses, in their homes, with the usual things that they can find, and also trying to get in touch with people through WhatsApp, to the phone app, and some of them in also by mail. So as I told you, once or twice a week, the sessions, home exercise in the rest of the days. And also we try to do 1 week educational session. Usually our program do a 1 week educational session. So we try to maintain that. And also we had included, not only in our center, but in a multidisciplinary and multi-center sessions about psychology. So we have had some help from the psychology department of the National University of Costa Rica, and they have performed psychological sessions through all the patients of all the centers. So we gather all our centers and all our patients at one time to talk about psychology and how to face the anxiety of the patients, how to face the fears that all of them have, and also all of us have also had in response of this infection that we are just barely knowing and trying to figure it out. In the cardiac rehab, the magazine of Costa Rica, La Revista Costarricense de Cardiología, that is the official publication of the Costa Rican Association, we issue a special, we printed a special issue, sorry, about COVID, and we include, of course, the exercise, the activity, and how to face it in this pandemic time. It was made by Dr. Severita Carrillo, that is one of our leaders here in the cardiac rehab theme. So some of the challenges is the Zoom. Using some of our patients, or many of our patients, are old, not very used for technology, and this app for many of us is also very new in the use. So we made a tutorial video of how to download the Zoom application, and it was shared with all of the patients. For some special patients, we have to do personal telephone contact to call them to see how they are, if they have some trouble with other things, and encourage them to go to the emergency department if needed. That is also, we are noticing that some of the patients come to the emergency department or to the cardiology departments very late. We also have performed yoga sessions for relaxations, not only for the patients, but also for the healthcare personnel of the Department of Cardiology, because we all have many things in our mind. And one of the major issues we have is when to restart our programs, when is going to be safe to restart the attentions. We are very expecting to see the recommendation of the health institutes even in our country, and also seeing other countries that are a little bit behind, advanced of us, to see how they do to manage all the recommendation and how to restart our normal life back again. Some of the things we also done in collaboration with many of our institutes have made to make donations to the people. We are a developing country, so for some of the patients, it's very hard to get including some basic needs for cleaning, soap. So we try to give them some of that things them to also have and to be safe. That would be my last slide. Some of the pictures of our country. Hopefully you can come when things get back to normal. And thank you very much again, all of for the attention and for the invitation.
Thanks, Dr. Quesada. That was great. So our final presentation is from Colombia, from Dr. Claudia and Dr. Monica.
Hi, Gabriela, do you have the image? Hi.
Sorry, I do. Just 1 second. I'm just going to share my
Okay.
screen.
Okay. Okay.
Here. Thank you.
Okay, so thank you, Gabriela, for the invitation to have this presentation in this webinar. In this brief presentation, first of all, I will be showing you the principal data relating to cardiac rehabilitation in Colombia in the era pre-COVID-19 and the general changes to the programs related to the actual situation. Then my colleague, Dr. Monica Rincon, is going to share with all of us the experience of Fundación Cardioinfantil program, which is one of the programs with the most advanced experience up to date in this new situation. Next, please. So let's begin. Next, Gabriela. Colombia is a middle-income country in development, like the rest of the countries in Central and South America. Next, please. With next, Gabriela. With a population of 45.5 million and with the cardiovascular disease as the first cause of death among the population. Next, please. On the basis of the data collected in the global survey from the responding programs published in 2019, Colombia has 50 programs spread out over 22 cities with a calculated national cardiac rehabilitation capacity of 19,500 patients per year. Next, please. 97% of these programs are located in an urban area, and 56% were located within the facilities of a hospital or medical center. Just under half of the centers offered phase 1 cardiac rehab, while 92 and 90% had phase 2 and 3. The programs offered 9 core components, and no program in Colombia offered an alternative cardiac rehab model like home-based model or community-based model. Next, please. This is a usual image of any session of any cardiac rehab program in our country. Next, please. Until COVID-19. In March 27, 2020, all the cardiac rehabilitation programs in Colombia canceled. Next, please. Next. Since that day, 12 programs of the 60 programs of Colombia in seven cities of the 22 cities are working in cardiac tele-rehabilitation. At the same time of this organization, the cardiac rehabilitation teams continue working with the patients through phone calls and chats, and some of them also with video chats, with video calls, trying to follow up on the patients, their habits, the adherence to the guidelines, and to motivate them to continue with these recommendations. Although the government has decreed and made public a flexible telehealth law during the pandemic time, each program needs to talk and create an agreement with each of the health companies to achieve the respective reimbursement. So up to date, to our knowledge, only 2 programs of our 50 programs are at this point. And that's why Dr. Mónica Rincon is going to show us the experience of Fundación Cardioinfantil program that is one of these two programs that is in this point. So please, Dr. Mónica, you can continue now.
Good morning, everybody, and thank you for the invitation. Do you see my slides? Hello,
yes.
Gabriela?
Yes, I can. Yeah, we can see. Thank you.
Okay, thank you very much. Okay, Fundación Cardioinfantil Instituto de Cardiología is one of the institutions in Colombia that is specialized in cardiovascular patients. We have our cardiac rehabilitation program since 1994. We have phase 1, 2, and 3, and we work as interdisciplinary team with physicians specialized in physical medicine and rehabilitation, cardiologists, physical and occupational therapists, and registered nurse. On March 27th, we have to close our outpatient program because the COVID-19 outbreak, and we continue with phase 1. But you can imagine the reduce in the patients because here in Bogota and in many cities in Colombia, people is very afraid about COVID-19. In that moment, we decide to develop and organize a telerehabilitation program. And this new model includes a video or a phone call. We only contact our known patients from our program, from phase 1, or those of continuity from phase 2 or 3, non-patients for first time. We contact them by phone, and they can choose if they want to continue this new model by video or by phone call. The patient preference depends on access to technology. And those patients who accept the video call, they receive an invitation through the platform. We use Microsoft Teams that is working very good for us. And each video call session lasts 1 hour. We have more or less 10 patients per group. And when we do the phone call, each call lasts 15 to 20 minutes. The physiatrist is whom performs the contact with the support of the cardiologist or the registered nurses or the therapist if it is necessary. Our session begins with the recommendations issued by the government and our Ministry of Health on avoiding the spread of COVID-19. But the main message for the patients and their family is to stay at home. So we do educational sessions. We have different topics. We currently have 11 topics scheduled, like coronary artery disease, medication adherence, high blood pressure, exercise and physical activity prescription, among others. Also, we have a video with stretching exercise and joint mobilization. And by email, the patients receive the exercise instructions. Always at the end of the session, we ask the current health status of the patients, and we answer the questions that they have about all the topics of cardiac rehabilitation. We have to record, we have to do the record of each session in the medical record of each patient, and that is the physiatrist's responsibility. This new model is carried out in the cardiac rehabilitation unit as long as the conditions of the pandemic allow it. Until now, we have done a video call with, we had contact 41 patients by video call and 39 patients by telephone call. And about patients in phase 1, you can see that in March we had 307 patients, and in April until last Monday we had only 22 patients. That is very, very, very sad. What we want is to do a follow-up of our patients, prevent deconditioning, keeping they doing their exercise, enhance the cardiac rehab benefits, and the most important thing, continue improving cardiovascular risk factor control. The future, we don't know. We are just living the present. We want to do the best of this new model. We know that we have to open our outpatient, but we have to wait until what is going to happen with this COVID pandemic here in Colombia. And we have to wait all the decisions of the director and epidemiology board of our institution. But yes, we have to think about what are we going to do with our outpatient program. We are working so hard with this new model, but the most important thing is to feel the happiness and the gratitude of our patients and their family when we contact them. Thank you very much.
Thank you so much, Dr. Monica Rincon. I am just trying to share my screen so we can finish. I know we've been I can share my screen, sorry. I'm gonna share my video. So I know we've been, we are almost 20 minutes of time, and I wanna thank all the presenters for the amazing presentations and all the attendees for sticking with us. We won't have time, unfortunately, to do a Q&A as planned, but we still have some unanswered questions, and we will do our best to answer all questions. And if you did not ask your questions, but you want to do that, you can use the ICCPR email, the same email that you used to register to this webinar. So we'll do our best to answer the questions. And this webinar, the recording of this webinar, as well as the answer to these questions, they will be posted on ICCPR website, which is globalcardiacrehab.com. I really want to thank everyone, and again, the presenters, amazing presentations, and yeah, have a good day. Stay healthy, stay well. That's the most important thing nowadays. Thank you so much.